anterior leaflet much less affected, and usually things are bad if an anterior leaflet is affected as well. I think it's important to start with the tricuspid valve apparatus in the first place. We know there are three distinct leaflets, the anterior being the most dominant. The terminology can be confusing. Anterior superior is another one which commonly used. Septal leaflet, which we can clearly see in our four-chamber view, so we shouldn't have any confusion regarding that. It's the posterior leaflet or posterior inferior leaflet, if you look at some texts, which is slightly difficult to review or slightly difficult to image. So probably short axis is a better way of looking at this leaflet than your normal four-chamber view. Again, the leaflet is quite small, slightly rudimentary. Generally, the function is not as important as the septal and the anterior leaflets. Hence, the size is in itself is quite small. There are three sets of papillary muscles which are quite small, and the cordia are arising from each set and insert to the adjacent leaflets. They complete the tricuspid valve apparatus. So when we describe a tricuspid valve, that's what you would like to see. Make sure that you see all the three leaflets and their attachments is how you would like to describe them. And this is the cut section of the valve, and you can appreciate what I just told you about in terms of the size of the leaflets. The anterior leaflet clearly springs to your face. It's quite dominant. Septal leaflet again plays quite an important role around the perimembranous region, and they are instrumental in closing a lot of perimembranous VSDs. And the inferior or the posterior leaflet is the smallest of the lot and probably has least functional capability. Coming to the anatomy of actual Ebsteins, or the pathophysiology of Ebsteins, is the adherence of the septal and posterior leaflets to the myocardium is the primary pathology, and there is significant apical displacement. Again, the terminology apical displacement might not be quite right. You're looking, it's almost like the true orifice of the Ebstein or the tricuspid valve is being dragged towards the outflow tract, or dragged almost as close as possible to the pulmonary valve. So it's more a caudal and probably a bit of anti-clockwise rotation rather than just apical displacement. Apical displacement is a convenient term we use because that's what we see on a 2D image. And again, 2D imaging is really a part of imaging rather than as we expand our whole spectrum, the 3D imaging really has revolutionized looking at the anatomy, and we probably can see more and we can describe things more and in a better way to surgeons than we previously were used to. The displacement or the malalignment, should I say, is more commonly seen or more readily seen in a septal leaflet and the posterior leaflet, and the apical one, the anterior one is the least displaced or least likely to be moved around. And as I mentioned, because of the different embryonic origin and embryonic delamination, that's least affected, thankfully. Again, we see atrialization of RV, which is quite obvious. If the valve leaflets and the valve orifice, true orifice, moves further down, there is an element of atrialization of the right ventricle. The myocardium in itself is not quite normal. It's quite thin. It functions almost as an atrial reservoir than proper contracting right ventricular myocardium. And rarely we also see redundancy or tethering and sometimes fenestration of the anterior tricuspid leaflet. And again, as a consequence of all of these, you always see dilatation of the right AV junction, which is universal to all types of Ebsteins, be it mild or moderate or severe. So this picture is just a schematic representation of what I just spoke to you about. You can see on the initial pictures how the true delamination should happen. While the failure of delamination results in change in the myocardium, the muscles gets thinned out, become more atrialized, and there is attachment of the valve leaflets to the myocardium, and the mobility as well is not quite as normal as it should be, and you can see some tethering as well, and then the myocardium in itself is quite thin and functionally not true right ventricle. This is just to show what we can see on a still image of an echo. And as you can see on the right side of the image, there is significant atrialization of the right ventricle, the small functional right ventricle at the bottom of the screen on the, and then you can see the left atrium on the left ventricle. And this is exactly what the surgeons see. So we have to really understand that what we show to surgeons and what they see on the table is quite visually different. So they have to use a lot of imagination of what we show to them and unpick if there's something we missed. So that's, I think, I always feel we should do our very best to make sure that we show and we give as much information to surgeons as possible. And there you can see what the image corresponds to exactly. You can see the functional true right ventricle, and you can clearly see the muscle or the myocardium is completely different compared to the atrialized portion. And the true junction of the right atrium is somewhere up here. You can see the septal leaflet there, on the atrialized portion of the right ventricle is quite thinned out as well. This again has implications for the conduction pathology. That's significant arrhythmia burden in these children, and we can completely relate why this happens. Again, these are surgical implications as well in terms of when they go in, they got to be careful in terms of what to touch, what not to touch. There's another picture which shows exactly what I meant in terms of the true hinge point of the true orifice, and the septal leaflet can move further down and almost head towards the right ventricle outflow tract. The further it heads toward the right ventricle outflow tract, more severe the pathology is, more reserve of right ventricle is eaten up by the atrialized portion of the right ventricle, and the functional capacity of the true right ventricle gets all that much diminished. So presentation, as I mentioned earlier, it really depends on the severity and the valve anatomy. Really, we've seen incidental findings on fetal imaging can progressively get worse, get to high drops, which again has implications with your lung hyperplasia, can have fetal arrhythmias. These are universally poor prognosis, even when they're born with high drops. Prognosis almost put as 50% really. Again, I've seen few of these who are born in high drop state, and you think, oh, that wall doesn't look that bad. So your mind gets almost tricks into thinking the tricuspid regurgitation is not that bad. Why is the kid so severely high drop? Why is the kid presented so badly? So I think we probably overestimate the importance of tricuspid regurgitation here. As I go further, we can talk a bit more about it. Again, in the neonatal period, they can present with significant cyanosis, the issues being a significant rise in PVR, elevated PVR, and the right ventricle isn't at its optimum and could not probably pump enough blood out into the lungs. As the PVR drops, you would expect things to get better if the right ventricle is able to generate more pressure and pump enough blood into the pulmonary arteries. Usually the clue is how well the pulmonary arteries are developing, if there's any pulmonary valve obstruction, if there's any evidence of especially the anterior leaflet billowing into the right ventricular outflow tract, that might potentially cause an obstruction. Although I think I would always take a clinical presentation in a child in the early neonatal period with a pinch of salt, just because things can change quite dramatically. You can see improvement in saturation, so you can see them gradually building up more blood flow into the lungs. And eventually I've seen them going home within 2 or 3 weeks, much better than what I had expected. Again, this is the background of them having a functional pulmonary atresia because of the right ventricle being underdeveloped and underperforming, with an additional burden of increased pulmonary vascular resistance. As the pulmonary vascular resistance drops, things tend to improve. This again is the background of children who are not having high drops or not developing any arrhythmias. We've seen babies with arrhythmias are quite intractable and they're almost impossible to control at times. That's usually a bad state for the child, and bad outcome is what we see in these children. We can see a bit as they get a bit older, we can see presentation with heart failure. The older children sometimes present with murmurs, sometimes just slightly lower saturations, maybe low 90s, high 80s, very subtle desaturations, usually with the resulting atrial communication shunting right to left. Some of the older kids might present with early exercise intolerance. Adults, again, we've seen classically present with arrhythmias who have milder forms of defects, but arrhythmias eventually will get to them at some point, and we've seen lots of children coming with some sort of arrhythmias at some point of their life. And in adults, that's usually one of the common modes of presentation, often one of the first presentations as well. Again, you can see why they can develop heart failure, and the shunting across the atrial septum can lead to embolisms, can lead to brain abscesses. This is some of the rarer forms of presentations, but relatively more common in adults than in children. As usual, we always have a few controversies and a few different classifications just to keep us interested. Selemer presented one of the first classifications way back in early 1990s when he was working in Great Ormond Street, and he classified based on the functional right atrium, which includes your atrialized right ventricle and the true right atrium as against the as against true right ventricle, left atrium, and the left ventricle. And based on this index, if the index is more than 1.5, the outcome was uniformly poor. Anything between 1 to 1.5, he still felt outcome was fairly poor. Less than 1 had better hope, and about 1 borderline most of the time they still did well. Great Ormond Street again put something else into the classification, and they came up with something similar, although they added an element of cyanosis and the age of presentation, and they gave a prediction for the mortality as well. That probably has stood as test of time for a while, I must say. As of now, I think what this professed seems to be quite reasonably accurate. So coming to Carpenter's classifications, it's based on the mobility of the anterior mitral leaflet, which I guess the surgeons would give a lot of importance to that. The point of cooptation, the degree of regurgitation, and the atrialization of the right ventricle. Full stop. So coming to the Carpenter type A, you see the atrialized right ventricle is small. The displacement of the valve, and again usually septal, is quite minimal. You still see some sort of mobility even on the septal valve, but you definitely see some degree of tethering. More importantly, the anterior leaflet mobility is quite normal, and it functions completely normally. Coming to the type B, a slightly worse variant, the atrialized portion of the right ventricle is much more prominent, much more easily seen. The posterior and septal tethering is very obvious, but there is still preservation of the anterior leaflet mobility, although you might see the point of cooptation might be an issue here, especially if posterior and septal leaflets are tethered, and the degree of regurgitation might be significant, which in turn will result in atrialized right ventricle being slightly larger. We're coming to slightly serious territory now with type C and type D. The atrialized RV is quite large. The tricuspid leaflet, anterior tricuspid leaflet is tethered and has shown significant restricted mobility and may also cause right ventricular outflow tract obstruction. This usually is not a good sign, especially you can imagine a newborn with already increased PVR and a poor right ventricle and significant atrialized portion. If you have further obstruction to the outflow, that impedes the pulmonary flow even further. And coming to the dark one is the Carpenter type D. Total processing of all the leaflets, virtually don't see any mobility. You almost see a single long tubular structure coming down, and just blood just pours into that. The atrialized portion is quite massive, and you hardly see any right ventricle. At best, you would see a little tiny portion of infundibulum, and before the true right ventricle starts, you can see the pulmonary valve coming into picture. So that's probably the worst prognosis of the lot, as you can imagine. Just to give a bit more structure to the Cellular index, this is exactly what he proposed based on the combined area of right atrium and the atrialized right ventricle, and divided by functional right ventricle and the left side of the heart. So if you go to the ratio less than 0.5 is classified as grade 1, up to 1 is grade 2, both of which carry good prognosis, while grade 3 and grade 4, where the combined area of right atrium and the right atrialized right ventricle dominates the rest of the heart, your prognosis looks pretty poor. And I think Great Ormond Street quarter mortality of about almost 100% on these ones. As we go through there we go. That's the Great Ormond Street echo score. They've combined the index, which is exactly what Cellular has proposed. They also include an element of cyanosis and also the age of presentation, and they predict the mortality is quite high, with the index being more than 1.1 in a cyanotic baby, while anybody with an index of more than 1.5 is universally fatal. And as you can see, the slightly better mortality on children who have a better index, and they quote less than 10% among them. So still, I think the bottom line still is a good echocardiogram is still probably the fundamental aspect in diagnosing and presenting good data to surgeons, and we should be able to give almost all the information what the surgeons would need. Although cross-sectional imaging have taken over a bit of imaging now, as they can quantify and also orient the tricuspid valve anatomy better, and that could be much more visually appealing for surgeons. More importantly, the right ventricle and the left ventricular volumes would also be much more standardized and quantified with an MRI. So just trying to, there's another crude way of looking at the measurements as well. If you can simply measure from the top of the right atrium to the point of septal leaflet tethering, and then you measure the true right ventricle, anything more than 2 times from the point of top of the right atrium to the septal valve tethering is usually, again, a poor prognosis. This is just a crude measurement, but people have employed this, and it's still stood the test of time. Let me try to show some pictures and see whether we can tease out what we're seeing here. So as you can see, the right atrium is hugely dilated. The septal leaflet, however, is tethered, although you can see the displacement is not too far from the crux of the heart. The anterior leaflet in itself moves quite well. This is the 4-chamber view. Again, if you see the anterior leaflet, quite mobile, well formed, a bit of tethering of the septal leaflet. You can see the LV is a bit squashed. The point of cooptation is somewhere here. This again doesn't mean the degree of regurgitation is severe. As we go a bit more, we'll talk a bit more. We'll get a few more pictures of them. As you notice, the right AV junction is quite wide open. The orifice is quite wide, and this is another view of 4 chambers in slightly inverted view, just to show your atrial septal defect, and also good movement of the septal leaflet. It's a bit of tricuspid regurgitation, as I mentioned, or ethmoid valve regurgitation, and the degree of regurgitation doesn't usually correspond to the degree of tethering of the septal leaflet. It's usually the anterior leaflet which has a good stay on it, and you can also see left to right shunting at the atrial level. Usually type A and type B lesions do have left to right shunting for a long while before, unless they're not operating, the pressures go up further. Shall we go to the next one? You can see a subtle difference between the previous picture and this picture. The anterior leaflet still looks good. It still moves very well, but it's the septal leaflet. I can hardly see any septal leaflet or septal tissue there at all. And the displacement is a bit more apical or more caudal, but it's almost like a little nubbin, as you see. There's hardly any movement there. Again, this confirms the same, and you can see the right from the true right AV junction, the septal leaflet is attached further down. There's another measurement which we all know. Any measurement distally from the crux of the heart more than 8 millimeters per meter square is significant. And you can see the degree of tricuspid regurgitation is slightly more because the septal leaflet is not playing its part as much as it should, while the anterior leaflet still is trying to do its bit and work as hard as possible. Okay. The next one. Again, just to show the degree of regurgitation, the anterior leaflet still moves very well. You can see that LV is a bit squashed, and you can imagine why there will be a bit of filling pressure on the left ventricle, and the left ventricle output can eventually compromise. And we can see in severe Ebstein valve, left ventricle almost getting squashed, and the volumes are barely acceptable. So I think it's important to assess the left ventricle as much as we do the right ventricle. So this is parasternal long axis, just looking at the origin of the septal leaflet where they're attached, and also this, you can see the anterior septal leaflet moves fairly well, and you can see the LV completely squashed, and the septum is, interventricular septum is getting flattened quite a bit as it takes the brunt of the filling pressure into the right atrium. The next picture shows again the true origin of true orientation of the right AV group, and you can see the coronary sinus there. You can see the SVC coming in. That's the true right atrium, while this is the atrialized ventricle, and you can see the posterior leaflet there and the anterior leaflet, which again moves very well, and the significant displacement of the posterior leaflet, while the anterior leaflet hinge point still hasn't changed much. It still comes from the crux of the heart, and it hasn't displaced downward, and still continues to move quite well. Let's go to the next one. This is a subcostal view, just to show slightly different anatomy in terms of if you see a subtle difference in the anterior leaflet, there is caudal displacement of the anterior leaflet over here. The attachment is not exactly at the crux of the heart where you would see it's almost you can see there's a caudal displacement of the attachment of the anterior leaflet, which again is not usual in a type B Carpenter's classification. However, there is some displacement further down, but the mobility is still intact, and you can see the septal leaflet attachment there, and the point of cooperation is somewhere over here. And as usual, you can see a significant dilatation of the true right AV orifice. So this is another picture just to show cross-plane imaging. Sometimes cross-plane imaging helps to assess the movement of the, especially the anterior leaflet. The picture on the left, you can see the anterior leaflet seems to move quite well, while the distal part of the anterior leaflet doesn't move very well in a different plane. So hence imaging in a different plane, just like how we do for VSDs or any other cardiac structure, is quite important, where we imagine different planes and give as much information as possible. And sometimes we see a part of the anterior leaflet is actually quite nodular, slightly different, almost gives a bit of myxomatous appearance. I think I've got a picture of it a bit further down. I'll try to show that as I go further. So as it progressively getting to the serious end of the Ebsteins now, you can see the anterior leaflet movement is not as well as we appreciated in the past images, and there is clear tethering of it. And then again, the septal leaflet is quite rudimentary and much more significantly tethered, and a huge atrialized portion of the right ventricle. So this will push the Ebstein's valve towards Carpentier type 3, and this is where I think the child will be clinically unwell and might need some intervention, or maybe beyond intervention. This is what I was trying to say earlier about the posterior part of the anterior leaflet. If you this is a posterior, so you're trying to look at the entirety of the anterior leaflet, and you can see the architecture is not quite normal. You can see little few nubbins here that doesn't move very well. It's quite bright, and this again results in slightly more tricuspid valve regurgitation or epstein valve regurgitation. So it's the anterior leaflet which has a significant say in the amount of regurgitation most of the times. Although septal leaflet is significantly tethered, it will still contribute to the degree of regurgitation. So this is the final part of the Carpenter's classification, type D. As I mentioned, it just literally one common chamber. I can't even see where the two right ventricles start. Somewhere probably right at the bottom of the screen, and whole of the right side is completely atrialized, just acts as a reservoir with a to and fro motion. And the point of cooptation is further down. Here you notice the degree of regurgitation is not that significant. So attributing too much to the degree of regurgitation may not paint the whole picture. It's the mobility of the valve with the degree of regurgitation, the atrialization of the ventricle, as well as the true right ventricle. A combination of all this is what matters. This is a slide I really want to show because the first heart sounds are generated by mitral and tricuspid valves, and because in Ebstein's the anterior leaflet mobility is impaired, it is a bit slow and it takes a bit of a delay in closing. There is a significant delay between mitral and tricuspid valve leaflet closures, almost to the degree of 100 milliseconds, which we can appreciate if you listen carefully. And you can see a prominent, you can hear a prominent first sound, and that's because of the abnormal anterior leaflet and it delayed mobility. And also, there's an important finding as well. If you imagine when you're doing a right ventricular assessment, you do a TAPSE obviously, and you can see the tricuspid valve excursion is quite good. There's another picture which I can show much. Yeah, you can appreciate the tricuspid valve excursion is quite good. This again is very important for surgeons. Very simple image, doesn't take a lot to do this, and it tells you that the anterior septal leaflet moves very well and it functions reasonably good, which we probably can demonstrate in a 4-chamber, but this again reinforces the same. So this is a picture which, again, I was trying to tell you about how the epstein valve is almost craving to go towards the right ventricle. And you can see how further down the epstein valve leaflets are, and you can see the pulmonary valve almost touching them. And this again, you can easily imagine why this can produce outflow tract obstruction if there is a significant anterior leaflet tissue coming through the outflow tract. This is another view which really helps surgeons gauge how far the valve is mobile and how close it is to the outflow tract. There's another X-plane imaging trying to show the picture in two planes. This is a classic inlet outlet view of the right ventricle. And again, you can see the true Ebstein's valve is somewhere up here, and you can see the orifice of the right ventricular outflow tract over there. And on the right hand of the picture, you can appreciate much better. You can see the pulmonary valve over there, and then you can see the epstein valve as close as possible to the right ventricular outflow tract. It's almost a modified inlet outlet view of the right ventricle, and we should be able to get these pictures with a bit of effort. Okay, next one. So this is again looking at the atrialized portion of the right ventricle, and you can see all the leaflets move quite well. All three leaflets, in fact, you can see all the three leaflets there. They move quite well, and they're quite close to the right ventricular outflow tract further down. And there is your pulmonary valve. Sorry, I couldn't make a bigger loop of this for some reason. And you can see the pulmonary valve coming down over there. Again, this is a short axis subcostal imaging of just to look at the planes of where the valves are, and you can see you need to really come further down into the left ventricle to even get a decent view of the epsteinoid valve. All the mitral valve is completely out of sight. It's almost mid-apical region of the left ventricle. You can't even see the papillary muscles there as well. So that again gives a degree of displacement of the epsteinoid valve. This is another picture which I was mentioning about how the epsteinoid valve can cause obstruction, can impede the flow into the outflow tract. And in some cases, we do see the dilatation of the infundibular portion of the right ventricle. This actually, in a case, measured about 5.5 millimeters. You can imagine the size of it if you think 5 centimeters of aorta is where you're going to replace the root. You're getting a 5.5 centimeters over here, just because of the anatomy and how the leaflet's causing obstruction. And again, I think the myocardium in itself in these conditions not quite normal, and we do see outpoachings of the atrialized portion of the right ventricles, outpoachings of the infundibular region, supposed to be the strongest, one of the strongest parts of the right heart, showing outpoachings, almost like you have a bit of myopathy kind of picture. And that's what the measurement was, almost 5.5 millimeters, as I mentioned. Sometimes we can see a pulmonary valve stenosis as well. This is a picture just to illustrate that. As you see, you can see the epsteinoid valve coming up to the picture here, and the infundibular region is quite normal, the laminar flow, while there is an obstruction at the level of the pulmonary valve. I've got another picture just to show the outflow tract across. There you can see the infundibulum is quite narrow. You can imagine why that could be obstructive, and the pulmonary valve in itself do look a bit thickened, and you can imagine that there should be a pulmonary valve stenosis as well. This is apart from your anterior leaflet might also potentially causing an obstruction. That tells you how difficult it is for the blood to get across to the lungs in these conditions. And again, the other extreme is the complete pulmonary atresia. We do see the physiological pulmonary atresia, but it's not uncommon to see complete pulmonary atresia with entirely duct-dependent circulation, which would obviously need early intervention. Physiological pulmonary atresia usually should get better next 3 to 4 weeks of the life. I've got a 3D image as well, I think. Yes, that's a 3D one. So we cropped off the right atrium and the right ventricle, and as you can see, that's the true right atrium. That's the right atrial appendage, the atrialized portion of the ventricle. And you can see the tricuspid valve plane, and that's almost adjacent to the right ventricular outflow tract. You can see a hint of the pulmonary valve over there at about 12 o'clock, 1 o'clock. It's the plane of this is what I meant when I say it's not just apical displacement of the tricuspid or the epsteinoid valve. It's more caudal and almost a migration towards the right ventricular outflow tract. There's another picture of the short axis of the valve. I think this helps for surgeons to look at the movements of all the leaflets, the degree of coaptation, defect, if at all, which is what we can see quite clearly here. And this helps them to how much mobility the tricuspid leaflets have, and how much surgical repair they might end up doing on these ones. Coming to the ECGs, as I mentioned, there's enough substrate in this child, even intrinsically, to have significant arrhythmia burden, and they are very prone to accessory pathways. We all know Wolff-Parkinson-White's common association, especially the right-sided pathways. They can develop AVRTs and rarely monomorphic VTs. Some of them have presented with monomorphic VTs, and this is a clear indication of an ICD in these patients. And as the pathophysiology changes, as the regurgitation increases, as the cooperation defect progresses further, you can see right atrium getting bigger, and you can expect atrial tachycardias, which probably is inevitable. Is probably Fontane's circulation 10 times worse, and focal atrial tachycardias, atrial fibrillations are quite common. And it's been increasingly recognized that sudden cardiac deaths have been seen in these patients, and often this would have been the first presentation in quite a few of them as well. So any slightest hint of palpitations in children with Ebstein has to be taken fairly seriously, and we should do everything to try to tease out what exactly is going on, and should be very aggressive in managing them. Some of the characteristic features are splintered Qrs complexes or polyphasic Qrs complexes, which we know are associated with myocardial scarring and are more prone for arrhythmias. Again, children with this kind of findings are definitely more prone for developing arrhythmias. The Qrs duration also plays a significant role, as we see in a typical phallus anatomies. And again, typically tall P waves, it's quite obvious that we see tall P waves in this condition. And this is the ECG I was mentioning about with the polyphasic Qrs complexes, as you can see in the lateral leads and also inferior leads. This is quite characteristic, not often seen, but probably more seen in adults than in children. Just to complete the picture, getting an X-ray on board, which showing the right atrium and huge dilatation of the atrialized portion of the right ventricle, and oligemic lungs with infundibulum hanging around there on top. I did mention about the cardiac MRI. The volumetric analysis and function plays a significant role. Usually, most usually in the second decade of life, we'll start looking at the volumes and see how well the right ventricle is scoping, what sort of volume the right ventricle is showing, and more importantly, the left ventricle ejection fraction, left ventricle and systolic volumes, any evidence of myopathy, any evidence of late GAD enhancement. All these will push surgeons towards acting on a bit more earlier than any physical symptoms. But again, it's quite tricky in terms of what sort of physical symptoms you take on board and try to intervene. Sometimes in this condition, you often see with the child would have survived a bit longer without us intervening, especially subjecting the child to such risky surgery. These are never easy decisions, as we know, as we discuss countless times in the meetings. So from the neonatal point of view, I've touched base on this already in terms of having low saturations. We know why they have low saturations with increased PVR and poor ventricular function. Prostaglandins would help mitigate it till the PVR drops. We have ventilated times, try to vasodilate them, try to decrease the PVR. Usually, if they don't need ventilation, saturations even on the lower side for a couple of weeks, we do see them gradually get better. And sometimes you've seen that develop a bit of gradient across the pulmonary valve as well. And that again suggests indirectly that there is an element of PVR which has been dropping down. And if there's not much improvement in the early neonatal period, which is usually a bad sign, and you don't see surgeons queuing up to do anything on these ones. I didn't go much on the surgical strategies at the moment. I'm sure somebody would like to take this on next week or the week after. These are few things which few things surgeons have got up their sleeve. Crohn's procedure obviously is quite sought after if the anatomy is suitable. Technically difficult, but it has shown excellent results performed by Dr. Da Silva from Brazil, and he's pioneered this surgery. Ideally, would like to aim for biventricular repair. Most often, we might end up with 1.5 ventricle, which is still acceptable. And of course, eliminating the right ventricle completely off is the stance procedure. Okay, I think. Oh yeah, I think looks like I'm done. Sorry if I not put you to sleep.
No, I must thank you so much, first of all, for taking out the time, Dr. Soda, for teaching us and coming on this platform. And secondly, for the excellent presentation, especially those lovely echoes that you showed that help us with the Carpentier classification and plan what kind of a surgery we can do for this patient. So thanks a lot for that. Um, we are open. Would you like to answer if there are any questions? Now is the time, guys. So it does look like there are no questions. And
No,
is
you're
there?
not.
Ram, sorry.
Is Arul, do you want to go first, or no? I just wanted to agree. Is Ram here?
Yeah.
Thank you for. I mean, it's a quite a very difficult anatomy to deal with, and quite a comprehensive presentation, explaining all the 2D, 3D, and the classification for understanding. I think it's quite difficult to cover the surgical strategies and surgical dilemma in one teaching, which is difficult. But I think thank you. I mean, thank you for summarizing and putting a comprehensive talk today.
Thanks. I thought the surgeons would probably be interested in having a say in this, isn't it?
Yes,
So that's why I didn't want to go too much into.
there is a presentation. Hopefully next week, I will be putting it online for other people to see who is presenting. I think Ramesh will, but then we'll see.
Like Arul wanted to say something.
Viral? No, he doesn't want me.
I think Crawford, yeah, Crawford has raised his hand.
Giri, it's Arul here.
Hi, Arul.
I was trying to ask through my computer, it was not working. So I was just going to check. General belief in Ebstein's is hypoplastic RV, right?
Yeah.
But because of the RVOT is quite dilated, if you do an MRI, I heard the volume will be bigger than the normal patients. So what do you do to that? How do you say it? Is it RV is normal, small, or if you include the RVOT for the assessment of the RV volume in MRI, it will be bigger. So how do you what do you say?
I think it's a very good question, but again, it's the anatomy is very similar as you see in terms of you have infundibulous dilatation in the phallus, and this is very similar. Although a lot of different cuts have to be taken to exclude the atrialized portion of the ventricle, and we do a lot more short axis cuts on this, especially in Great Ormond Street, where Marina Hughes is quite keen on these pictures. Especially the surgeons really want exact volumes, and we've seen the volumes almost 2 or 3 times. Actually, you're absolutely right. This is the background of LV being squashed. The RV volumes are quite huge, and we often see the volumes which are almost as big as US severe PR phallus volumes, or even more than that.
Can I may be somebody, but then can I just say something on the RV muscles? I think what I understood is that it's also the muscle is RV muscle is not it's kind of dystrophic and it's not good enough there is also more spacing between the cells and how they are formed inside. So they don't act like a syncytium anymore, and that is why the volume increases, because it just dilates, but it is not able to generate any pressures. So
All
it's
right.
not.
Okay.
I mean, I might have one of the child had a volume of maybe I can get that for report, the MRI report on that one. I'm trying to figure out whether I can show it. I'll probably show it tomorrow when I come across that. But I've seen significant RV volumes.
um okay, so I think Crawford had raised his hand. Do you want to ask anything, or?
Have we got time, Garima?
Yes, please.
Just one question. Thanks very much, Gary. We recently had a patient that was quite severe on the ICU with a very severe Ebstein's, who had this idea of a circular shunt with high PVR and was in a very difficult physiological position. The decision from the group had been to wait for the PVR to drop, but unfortunately the PVR didn't drop and the baby ended up dying. Is there any other medical, probably not, or surgical management in that position, or is that is the mortality 100% when it gets to that case anyway?
I think so. I think there's an element of pulmonary hyperplasia, parenchymal issues as well with these children, and which may not be subtly picked up, or antenatally may not be picked up. And then, as if the PVR doesn't drop, there's not, you try as much as you can medically to try to drop and see, but we can't force blood into the lungs unless the lungs are prepared to accept it to a certain degree. And if all the medical treatment is futile, usually they don't do well. And the sicker the neonate is, most poorer the prognosis is. And even though the baby doesn't clinically present with high drops, that's usually associated with bad prognosis. But the other spectrum you mentioned about the pathology is further distal in the parenchyma, and if they don't let the blood in, there's not a lot we can do really. With optimal medical management already in terms of nitric and further more vasodilators, if things haven't dropped down. I've seen children with low saturations with not able to get the sats up, and people do panic a bit for a week or two, but most of them we wait for 3 or 4 weeks. They do well, and the lactates are good. Clinically they're well. It's just saturation sometimes are a bit unnerving, but the babies themselves do quite well, and you know that eventually they will the lungs will yield and they get enough flow, and we've been able to send them home. In fact, last 2 weeks with another child we had to wait for 4 weeks to things get better, and then the duct is closed as well to make sure that they can maintain antegrade flow through the smaller right ventricle into the pulmonary artery without the help of a duct, and they generally tend to do well, those children. But the one you mentioned probably wasn't deemed to be surviving.
Thank you.
Right. I'd like to thank. If there are no more, are there any more questions? All right. I'd like to thank everyone for the nice discussion at the end, and thank you so much, Dr. Giri, for taking out the time and for this lovely presentation. We hope to have a surgical presentation next week on Ebstein's.
Thank you.
Okay. Thank you so much.
Thank you all.